Hi, good afternoon. We are back at the Global Neuroscience Institute conference, and we are going to really change things a little bit and talk about something that has a wide applicability, and that is memory. Right now we have our leaders in memory, which include Dr. Peter Gliebus, Dr. Kate Lester, and Dr. Jen Gallo. And I think I'll just start off with you, Peter, if I could ask you to tell us, more than just Alzheimer's, why do so many neurological conditions present with memory impairments?
Well, Adam, thank you. I think this is a perfect question to start this conversation because when we're talking with the patient, we're dealing with the patients in the clinic, we encounter almost every second patient who comes in with any neurological problem, and I don't know what your experience is, but the forgetfulness is always there. I would like to take a couple minutes just to review the maybe anatomy, simplified anatomy, and if we could just show the slide. Here it is. It is a little bit oversimplification of our memory system, but I think it will give viewers a good understanding why so many neurological disorders affect memory. To make it understandable, we can divide our memory process overall into encoding, that is how we take the information, the retention, our brain's ability to store the information for future use, and the retrieval, that is our brain's ability to reconstruct the memory that is already in the brain at the correct time. And there are a little bit different parts of the brain that are involved in all these three steps, and if any of that mechanism is not working properly, people might experience forgetfulness. For example, if you look at the upper picture where the encoding is, the parts of the brain that are important, that are frontal lobes and connections with parietal and temporal lobes, as well as the medial temporal lobe structures that start acting for the encoding. And then after that, you see that also the lateral temporal lobes are important, that are working on information processing. The second stage is that the retention, that our ability to retain the information, and that is heavily dependent on the medial temporal lobe structures and their connections. And the third function is the retrieval, that is our ability to find, or our brain's ability to find the correct information. And again, the executive networks, those frontal networks and the connections with the temporal lobe networks are involved as well. So the reason for this is I think what is very important to understand, there are these three steps and different parts, a little bit different parts of the brain that are involved, and if we have any problem in any of these steps in any of these networks, then people might have forgetfulness. To complicate things a little bit more, I'm probably going to complicate things more, there are the temporal limbic structures that are connected, that form what we call the PAPE circuit. And not going into the details, it's many interconnected brain areas that we think are important in information reverberation and retention. I think that would be one of the main reasons why memory is affected with so many disorders. Now, when you're examining the patients, when they're coming in with forgetfulness, what other things are you considering?
Well, because, you did a beautiful job of sort of exemplifying how widespread the memory system is, and there's so many different regions of the brain that have to work together to really create and retain new memories. Any part of the process that gets disrupted will lead to perhaps what looks like or what feels like to patients as memory loss. One of these issues is attention and working memory being the ability to kind of hold information in mind, manipulate it in the moment. I call it complex mental tracking a lot, just tracking information in mind. And when a patient is not alert or not attentive when they're being exposed to something new, they're not going to learn it in an effective way to make it later retrievable. Another issue is with executive functions, which is kind of a very broad, heterogeneous group of cognitive skills, but things like organization and associative learning, which are really important for getting information encoded in a way that facilitates later retrieval can interfere with that memory process along the way. And, Dr. Gallo, do patients typically come in, are there other kind of deficits in cognitive domains that might feel or might be reported by patients as forgetfulness, but are really not even part of that system?
Definitely. When patients come in, I think it is easy for many different types of changes in cognitive ability to appear or feel like a memory failure to them. So for example, it's really important for me when patients come in and they're reporting forgetfulness to get really specific examples of what their experience is from the patient themselves, from caregivers, significant others that have an opportunity to observe the patient in a day-to-day context, because sometimes what we're talking about feels like a memory impairment might be really more an impairment in the language system. So as an example, one of the examples that I try to get from them is, tell me what it's like what is it that you're noticing that's different about your memory? And oftentimes family members will say, well, mom or dad doesn't really remember what words are anymore. So and it's not just the names for things, they just cannot find words. Or I say something to them and they don't seem to remember what that means anymore. And so that sort of suggests that there really might be more of a problem either with retrieving information that again is not necessarily memory specifically, but maybe just a more general access problem, or a comprehension problem. If they are not understanding information, it's a little bit different than sort of being able to encode new information. Similarly, it may be a report that they're having some difficulty remembering how to use objects or learning the routine for they got a new cell phone and they're not learning how to use it really well. Again, this really might be related to memory in some ways, but it's more of a procedural memory problem, or memory for actions. The action system and routines of behavior is disrupted. So there really might be something more or in addition to a more sort of formal memory proper kind of impairment that's going on. And so getting specific examples of what they mean by memory might elucidate the presence of a memory impairment plus impairment in other cognitive abilities as well, not just memory.
I think that's an excellent point, that even when we teach students or residents, when they come in and they tell, oh, the patient is here with a forgetfulness, that you dig in deeper to see, is it really a memory problem or not? And if it is a memory problem, then obviously you sort of know, your territory, what to look for, how to work that out. I know that our talk today is beyond Alzheimer's disease, but I don't think we can skip Alzheimer's disease altogether, not talking about memory, because it's such a prototypical disease. The Alzheimer's disease is one of the most common neurodegenerative disorders, and it is, people develop it usually, over the age of 65, but some younger forms. Pathologically, we find, several types of pathology, but one of them is amyloid, changes of amyloid in the brain. We know from the studies that it occurs, probably starts accumulating that bad amyloid, maybe a good decade, 2 decades, or even 3 decades in the brain before the first symptom starts. And then when the second pathology sets in, that is tau related, that inside the nerve cell pathology sets in your crucial memory areas, in the medial temporal lobe structures, in the hippocampi, that's when people start having symptoms. Again, if we can show this slide just a little bit, the slide demonstrates a healthy brain on the left and the brain with somebody who has Alzheimer's disease on the right, and you can just to explain that you see that Alzheimer's disease kind of this generalized atrophy, the shrinkage of the brain. But if you look at those areas that are colored, those are the crucial memory areas, very important in memory transfer from the short term to long term. That's how our brain notes what's happening around us and stores us for the future. Maybe you could explain a little bit what are exactly, when talking about Alzheimer's disease, what is that memory impairment we see? And when we're going to try to demonstrate why it is a little bit during the testing, actually, it's one of these different patterns that we see comparing to all the other neurological disorders, and that would come to, to the original question, why so many diseases present with memory, but they have different patterns.
Yeah, for sure. So the disease process, as you just described, follows a pretty characteristic progression where the disease begins in the brain and how it progresses throughout the brain as the disease itself advances. The clinical signs and symptoms, which really come across as the characteristic cognitive impairments in Alzheimer's disease, follow the neuropathological changes in the brain. And so one of those first areas being affected being the areas that are primarily responsible for learning new information is going to be one of the first clinical signs or symptoms that patients experience. And so characteristically, memory, specifically declarative memory, learning new facts and information, is going to be a lot harder to accomplish even in the very beginning stages of this disease process. And memory then being the first and most prominent clinical sign or symptom, then progresses most specifically as the disease itself progresses, and then comes to include other cognitive abilities in sort of the impairment profile. But for the most part, in Alzheimer's disease, the memory impairment is one of an inability to really encode, create new memory traces, specifically for information, episodic experiences, personal time-tagged experiences from the point of the disease process forward. And so it pretty much presents with almost a paradoxical presentation where the patients have a really hard time remembering information that may have been just shared with them a couple of days ago, maybe even a couple of minutes or a couple of hours ago, yet they have no difficulty recalling information, remembering information from years ago, maybe even decades ago. So it's really this difficulty learning new information. It then tends to be accompanied by, because some of the same brain networks responsible for this memory impairment are also responsible for processing language and semantically based memories, more general information. Those language problems are going to be the second most common symptom. So you tend to get a really heavy memory encoding, a retention impairment profile with Alzheimer's disease, plus language, maybe visual-spatial skills, executive control, attention, that just progresses as the disease progresses.
For me, it's always fascinating to talk about the memory, because when you think about it, we're constantly being bombarded with information, and it's just, how intricate that mechanism is that our brain's ability to record it. And it's not only just a recording, you have to record it in the correct sequence, and then your brain then is able actually to correctly recall that sequence and everything. And another fascinating topic, which is completely not for today, is our brain's ability actually to filter and forget information. Not everything can be, but again, that's for the next talk. So our talk is beyond Alzheimer's disease. So we definitely have to move on and talk about other disorders that can present with a forgetfulness. One of the second most common neurodegenerative disorder would be dementia with Lewy bodies. And dementia with Lewy bodies, where the patients present with these fluctuations of the cognitive state fluctuations. That could be from some just mild confusion and then reverts to normal or near normal or whatever is the baseline, or to more significant fluctuations, so the staring spells, or even sort of these unconsciousness spells and they come back. Other symptoms would be cognitive by definition. And just for the viewers, when we are saying dementia, the new term for the dementia is a major neurocognitive disorder, but it's just so ingrained in us, and it's easier to say that every time we say dementia, we are aware that the new term is major neurocognitive disorder. The second would be the cognitive problems, and I'm going to ask you actually to talk about those cognitive problems, which forgetfulness is part of it. People frequently forget in clinics. I frequently get patients who come in as a primary complaint forgetfulness. And then other symptoms that we see with the dementia with Lewy bodies would be Parkinsonism. Like, I mean, they're getting slower, they might have tremor, they might be rigid, their balance is worsening, the gait is changing, their facial expressions are changing. The other typical symptoms would be acting out dreams. The new onset of acting out dreams, at the age of 50 or 60, they start, acting out dreams, and the second part, especially in the second part of the night, and that, why it is important and to even look and diagnose is because that could be very significant. I had patients who injure their bed partners. They start while sleeping, kicking and punching, or they fall out of bed. One patient I had who broke their bones because it was such a violent acting out of dreams. And there are other symptoms, such as autonomic symptoms. They might have fluctuating blood pressure, etc. But I think the main question here, that cognitive part, and Dr. Lester, maybe can you comment on what type of cognition problem we see?
Right. So, I mean, you touched on the fact that, dementia with Lewy bodies, the cognitive profile, it's really kind of characterized by these fluctuations. And, a patient may look quite sort of disoriented or confused one minute and look sort of more normal or at their normal baseline performance level the next. And oftentimes those fluctuations in cognition are accompanied by or go along with, fluctuations in alertness and arousal. These patients oftentimes might look excessively drowsy during the day. They might wake up from sleep with an acute and transient kind of confusion. They tend to do better in environments that are novel and stimulated to kind of keep them aroused and alert. On neurocognitive testing specifically, dementia with Lewy body typically presents with, 3 primary areas of deficit. Attention typically is affected, as noted, executive skills, and actually visuospatial skills, which sort of that pattern exemplifies how there's both subcortical and cortical involvement, the latter of which really differentiates, patients with dementia with Lewy bodies who have a Parkinsonism, differentiates these patients from other Parkinson's or Parkinson's plus type kind of performance profiles. So these patients on testing might look very distractible. Working memory tends to be affected. Executive skills like mental flexibility, their ability to kind of both attend to and stay on track, but also shift focus or change in response to something in the environment. Complex problem-solving skills, both perceiving visual inputs as well as reconstructing visual stimuli. All of these areas of cognition tend to be affected. Now you'll notice I didn't mention memory yet, but as we know already that these other systems, right? Let's get to the point. So memory, not what we kind of think of traditionally as memory or this storage and retaining information, but the problems with dementia with Lewy body, such as the attention and executive components, really do interfere with those first and third steps of the memory process that you mentioned. So learning new information, being able to retrieve new information when it's time. If a patient is distracted and not alert or not aroused or not attentive during exposure to something new, they're not going to learn it. And then down the road, they're not going to recall it. They also might look kind of repetitive because of a tendency towards perseveration or getting stuck on an idea, this kind of frontal component. They also tend to struggle with differentiating where new information came from, what we call source confusion.
All right, so just for, again, to go over the way we were talking to look at the memory, and this is so oversimplified, these 3 steps, and frequently the same things are happening at the same time, but just for viewers to understand, again, we're talking about that initial step is encoding, it being able to put the information in the brain. The second step is that transfer that information, into the storage, and the third step is to find information when we need it. So if Alzheimer's disease affects the typical Alzheimer's disease, affects that middle stage, that retention ability to put to transfer that information along storage, the Lewy body more tends to affect that either that initial encoding or finding when it's needed. But whatever the information, if it's encoded, it's more likely to survive in Lewy body than in case than in Alzheimer's disease
Right.
case.
They may need a little support kind of accessing
Accessing it, but it's there. It's more likely that it's there than in Alzheimer's disease. If we can show the slide just for a second, and this slide is just to demonstrate the how the brain looks for the dementia Lewy body, and for people who are used to looking at the MRIs, you can actually see that dementia Lewy bodies on the MRI. We see just generalized atrophy, and actually, in the typical cases, the areas of the brain that are affected, the areas of the brain that are important in that memory retention are spared. Okay, and again, there are many cases when actually that Lewy body and Alzheimer's disease coexist in the same patient. So the third most common cognitive-related neurodegenerative disorder would be frontotemporal dementia. Frontotemporal dementia is very heterogeneous disease. It's a syndrome, and we group them into these behavioral variants and these language variants. And I would like to not to talk about language variant today, but more about this behavioral variant. And this disease tends to present more in younger patients. And it has higher genetic possibility that it is genetic loss. Up to 20 or plus percent of people have the genetic predisposition or mutation to develop the disease. These are as all of these diseases are tragic, but these are diseases with the usual presentation, either some sort of psychiatric presentation or the changes in the personality. People change, they were the nicest, the sweetest person, and then they become this, the coldest, no empathy, no sympathy person. Disinhibited people were very socially appropriate and start acting inappropriately in front of other people or behaving, or they withdraw. They withdraw from whatever they like, they don't like anymore. They become apathetic. Some of these patients develop also the motor symptoms, might develop this, the frontotemporal dementia, amyotrophic lateral sclerosis, that they start having, also losing their motor function, or some of these patients might have also the Parkinsonian syndromes. But again, this is a very wide spectrum. The syndrome has so many possibilities, and even if it is genetic, the same genetic mutation in different family members can present with a little bit different clinical presentation. But again, going back to memory, what we see, because these patients frequently end up in the psychiatric clinics initially, but when they come to us is, again, the symptom, what brings to neurologist would be forgetfulness. What is going on with memory with the frontotemporal dementia?
Yeah, with these patients, particularly earlier on in the disease process, when a general problem is first noticed, the problem, as you were describing, really tends to be a little bit more behavioral. Tends to be a change in the person's personality, their psychiatric status, perhaps their social behavior. So they may begin to behave a little bit differently than they would typically behave, having a harder time matching the tone of a situation to sort of maybe a more sort of fleeting tone, finding humor in scenarios that are not typically humorous and that they may not have normally found humorous. That brings, that change, that general change in behavior is typically what brings them in to see us, and sometimes on the testing, particularly earlier on in the disease course, does not show a lot of impairment, particularly in the area of memory. They look quite normal on testing, which sometimes, along with the clinical history, the described changes in the person's comportment and interaction style, and their ability to apply the normal sort of conventions of their typical self in a day-to-day context, along with perhaps some changes on imaging that show characteristic atrophy in those regions, but along with more or less normal cognitive profile, is sort of what leads you towards this is probably, yes, a degenerative process, a dementing process early on that is just not showing a lot of clear memory-based cognitive decline. Certainly, as the disease progresses, because of the involvement of the frontal lobes, you're going to see planning problems. You're going to see a lot of perseveration, a lot of those frontal signs, maybe a little bit disinhibited. Their inhibitions are released a little bit more. Organization. attention, having a harder time not getting distracted by, salient information in the environment. That's going to make it hard to attend to things that need to be attended to. It's going to make it hard to retrieve information in a meaningful, organized, efficient way when it's needed. That's going to show up on the testing, on executive-based measures, also on memory, as difficulty getting information into the system, difficulty getting information out of the system, more so than an a retention problem, being able to really get it in and retain it for later. Once the disease progresses, though, the memory impairment tends to catch up later and sometimes can even progress at a more rapid rate. The forgetting you see at a more rapid rate than someone in a similar disease stage of illness in Alzheimer's disease. So this is sort of a profile where the memory impairment arrives late, might progress a little bit more rapidly, but might not be as prominent initially.
Follow-up questions. The one thing and I'm sure majority of viewers know when what is executive function when we say, but we use this word so frequently that probably we just want to clarify that we're on the same page. What is the executive function?
Yeah. They are it's sort of an umbrella term. If you think a little bit about the executive of a company, they sort of sit at the top and they monitor everything else that goes on. It might be their responsibility to help coordinate certain units and sort of have other units back off for a minute. So when we talk about cognitive ability within this executive functioning area, it's really an umbrella term that refers to a lot of things. Being able to inhibit impulses, being able to organize your own behavior, being able to sort of combine different aspects of other cognitive abilities, being able to sort of reflect on the past and imagine the future is an executive control task. Mental flexibility, planning, problem solving. It's really not one thing. It is a bunch of different things. And not all executive abilities are necessarily affected the same in someone with, a disease process affecting the tissue in the brain that tends to affect executive functioning more broadly.
Right. I'm just going to add that, on neuropsych testing, most of our executive tasks sort of get at the dorsolateral cortex and reflect differently in behavioral variant FTD. It's oftentimes those sort of orbitofrontal behavioral changes that we see. So it's not always a perfect combination of seeing those behavioral changes in the real world and then coming in and performing equally poorly on the executive tasks on neuropsych testing because they do sort of capture different skills.
Yeah, and you mentioned that these patients with frontotemporal dementia, initially they might not have any even cognitive deficits because the parts of the brain that are affected are more these behavioral control, behavioral monitoring parts of the brain.
And the online processing of it. Oftentimes they retain the knowledge base that they need to sometimes be able to, in a very structured, sort of systematic testing session, they can respond appropriately in this very sort of controlled, structured environment. But when it comes time to apply that fluidly or in a novel scenario, they have a harder time negotiating that novelty and the sort of on-the-fly processing element of it.
So Dr. Lester, so why do these people, if we're talking executive problem, why do these people present with forgetfulness? How does that intersect with the memory?
Well, because the frontal subcortical networks in the brain are really important in acquiring information when they're being exposed to something. So executive functions, I include really complex mental tracking or that working memory. A patient who is losing track of what's going on and not really focused on what's going on isn't going to learn. When they're, not making associations or organizing information in a way that sort of facilitates later retrieval of new information, they're going to look like they're having trouble with recall when they're just having trouble accessing, that information from the storage system. So these executive skills like organization and complex mental tracking are really important in those first and third steps of the memory system.
So just again to summarize for viewers is that, again, we started with Alzheimer's disease, that retention problem, the second step, dementia of Lewy bodies, we're seeing like encoding and retrieval problem. Do I hear the same for frontotemporal dementia also? Possibly initially encoding a retrieval. There are a subset of patients in frontotemporal dementia that might have this retention problem as well, but we're talking about the majority of cases. If we could pull up the slide, and this is just to illustrate the frontotemporal dementia, which parts of the brain are affected. Again, as the name implies, these are frontal temporal lobes. These are the lobes that are significantly involved in all of the 3 steps of the memory formation, and that's why forgetfulness is such a big part of these diseases, subjectively, objectively. Okay. So the next condition we cannot skip is the vascular cognitive impairment or vascular dementia. Again, we should stop using this word, but it's just so much easier to use it. So this is all the cognitive problems because of the vascular compromise, whether it would be ischemic compromise, strokes, stroke-like events, or these white matter changes, what we see in the brain, or the hemorrhagic events, intracranial hemorrhages, et cetera, that affect. Now, these diseases are so the way sometimes I say you see one patient, because it all depends what part of the brain was affected. And even the same forgetfulness might have a little bit different flavor depending on what part of the brain is affected. Just a clear-cut stroke in the posterior circulation affecting your hippocampi, people can be have these retentive problems. They can present like acute Alzheimer's if you put it that way. Okay, but a majority of them probably present with these other types of what actually. I'm going to ask you to talk about that. Now, how do we diagnose? Typical presentation. How we were taught and how we're still teaching is the stepwise deterioration. The people get worse, then they stabilize, then another vascular event, they get worse, they stabilize, and they slowly worsen and worsen. We frequently don't find that in the clinical setting. We frequently still present with these slowly, seems like progressive, maybe you can't really pinpoint that little step when it happened. Aside from just cognitive problems, these people might have also motor problems, these nonspecific hypokinetic slowness, balance problems, and all that. Now, I'm not talking about the very specific strokes that can affect, and stroke syndromes, but it's more about this subcortical. And if we can pull up the slide, again, this is just to show vascular cognitive impairment with all these white matter spots. When we were talking about the executive networks involved in the memory formation, look at all these white matter spots, of course it's going to touch those executive networks. And that's why people will have trouble with a encoding or retrieval. Am I right?
That's right. So, in terms of the cognitive patterns we see with vascular cognitive impairment or vascular type dementia, it's really variable. Patients can have a stroke in a very critical memory area, retention area, thalamic stroke, mammillary bodies, something that causes really a dense amnesia and looks maybe more like this chronic retention issue versus a more slowly progressive white matter burden, this small vessel ischemic disease, which affects the white matter and those tracts that sort of communicate information from the frontal lobe, which is so interconnected with the rest of the brain that information has to be transitioned from the frontal lobe to the storage centers and back out again. So when there's disruption of those tracks, information gets slowed and information gets transferred inefficiently. So the frontal lobe, which is, we're driving this point home, is so important in learning and retrieval. If it can't communicate with the rest of the brain to get information stored and then accessed again, we're going to see this same kind of profile with the vascular type dementia as we see with some of these non-Alzheimer's type forgetting profiles where there really is impact on the first and third steps of the memory system.
Something else that sometimes also helps disentangle whether there is vascular dementia and maybe not Alzheimer's disease or perhaps even combined Alzheimer's disease is that given this predominant impairment really with retrieving the information, sometimes with something like a vascular dementia, you see that the individual also has trouble retrieving older information. It doesn't matter, the new learning is not the only learning that is hard for the patient to get out of the system. Even the older information is harder to get out of the system. So if it's not isolated to just a lack of ability to retain and create new memories, and that's the basis of the, the inability to recall information later, then sometimes it really leans more towards a vascular kind of profile.
And to bring even more confusion to the picture, vascular cognitive impairment frequently coexist with Alzheimer's disease as well.
Right.
So then you start seeing all these mixed pictures, and
Pieces, and so that's how you begin to narrow down and really kind of come up with a diagnosis that is likely to be most helpful to the patient and the treating provider and the family members for how best to manage and what to expect moving forward.
Can I just jump in and explain a little bit about how we differentiate a retention from a retrieval problem on testing? So, if many of you out there are probably familiar with MMSE and the memory item on there, when a patient is asked to recall information, how do we know if they're having trouble? How do we know if it's because they couldn't learn it, because they didn't store it, or because they didn't retrieve it efficiently? Neuropsych testing really kind of gets at that distinction by using these kind of learning trials to see if they can benefit from repetition. At that delay recall, if they're having trouble, if we add supports, if we make it easier for them to access the memory, do they improve? And when patients do improve, it really does demonstrate that it was stored and really more of an access issue.
So you have tools I guess that's where, we can do it in the office, but probably nothing can be better than objective neuropsychological testing to get the answer.
But also tips for using in the office. If a patient can't recall spontaneously on the MMSE, you could add some cues.
Yeah, absolutely. And neuropsychological testing will help you to differentiate whether it's really a memory problem or language problem or visuospatial, or what does that forgetfulness really mean? The next, so just before we're going to go to the next condition, again, to summarize, the vascular, aside from the very typical stroke syndromes, the vascular dementia is again more encoding and retrieval problem.
Those frontally mediated.
Frontally mediated. Again, we had Alzheimer's disease retention, we had dementia of Lewy Bodies encoding retrieval, frontotemporal encoding retrieval, vascular encoding retrieval as well. Again, majority of cases, there's, as I say, human cerebral biological systems. Everybody has a little bit different, maybe makeup. Next condition is normal pressure hydrocephalus. That is the condition we definitely want to talk about because it has a totally different treatment. And actually, it has a treatment and it has an intervention where we can really significantly change the trajectory of how these patients feel, perform, live their lives. The typical presentation for normal pressure hydrocephalus would be the triad. We know it's cognition, cognitive problems. I'm going to let you talk about that. The gait problems and some autonomic symptoms such as urinary incontinence. The gait problems, typical magnetic gait, small steps, cannot lift their gait, cannot turn. It's actually, when you see it a couple times, it's very, almost becomes this typical gait. What is going on with the cognition?
So with normal pressure hydrocephalus, we know that there's the hydrocephalus process is going on, which means those ventricles, primarily as you can see from the images, that those ventricles are being enlarged. And something to keep in mind is that the skull, really the brain is contained within a closed system. So that skull is hard, it's the outer coating, it's really not going to give much. So if those ventricles are enlarging, the tissue doesn't have a lot of place to go. So the expanding of those ventricles is going to compress some of the tissue. And you're going to get a lot of that compression in those central regions. So with normal pressure hydrocephalus, because it also, for the most part, tends to be a relatively slow process, you do get this progressive impairment. It tends to present with some general cognitive disability, primarily with slowing of cognition, as well as in some cases gait and motor movement. But the individual is going to be sort of just a little bit more suppressed, so to speak, overall from a cognitive standpoint. And because those ventricles are enlarging and compressing the tissue that would otherwise need to communicate, distributed areas needing to communicate with one another, you get a somewhat broad pattern of impairment, but you can tease apart certain kinds of, relative relationships between the cognitive impairment. You get a lot of attention problems, processing speed problems, and executive control problems, primarily because for a lot of the same reasons why you see these kinds of impairments in vascular dementia, you're disrupting the communication amongst the otherwise healthy tissue that is being somewhat temporarily compressed as a function of the enlarged ventricles. In terms of the memory impairment, also, some of these, Papes circuit and all of these medial structures that are responsible for facilitating not only just the, in learning and retrieval processes of memory, but also the encoding process, you can get a somewhat variable memory impairment profile. It does tend to be a little bit more retrieval-based, disproportionate difficulty getting the information in or getting it out, but you can also have a retention problem in these patients. Really, the cognitive profile in normal pressure hydrocephalus looks a lot like a vascular dementia profile, which becomes a rule out, and you really want to make sure that you identify something like normal pressure hydrocephalus early, because it does have a particular intervention that is not available in cases of more sort of traditional vascular dementia. You can minimize the degree of potential permanent damage that is created by the compression of this tissue and not have it be a more permanent sort of, impairment profile even once the patients improve from the treatments. But it looks very frontal subcortical overall in terms of the general cognitive impairment profile and then even that memory impairment profile.
I totally agree that, it's a mixed picture. Yeah, it's more retrieval, encoding, but we can see because just anatomically if it is on those Pape circuit structures, the fornix, that, or pulsatile or whatever pressure is, it's still by definition normal pressure, but it has to be somewhere pressure, at some point, that can affect the retention as well. If we could pull the slide, just again to show for the normal pressure hydrocephalus, how do we suspect it's when the ventricles are enlarged more than we would suspect when we compare to the cortical atrophy, and there are some indexes we can use to calculate that, but it's just for visual. And then there are sometimes also the fluid collection might be not even in the ventricles, but in the subarachnoid space and in the parasylvian fissure. How do we diagnose this condition? Obviously, if we suspect that, we usually remove a large volume cerebrospinal fluid, doing this usually the spinal tap, and see whether that relief of that pressure actually will make any change. And if it does make any change especially in gait or cognition, then obviously these patients are candidates for more permanent solution, how to take that fluid out, and that would be the ventricular peritoneal shunt placement or other shunting procedures. So again, this is the condition always to think about because it has such a totally different treatment, and actually I've seen patients where they normalize return, or maybe not forever, but for a good amount of time they really normalize and they go back to work even. So again, to summarize now, when we are talking about that, the encoding, retention, retrieval, where does the normal pressure hydrocephalus fall into?
I would say a little bit of a mix of both. You're maybe more likely to see some of that sort of, encoding and retrieval difficulty, but it can be both. And it's going to affect both verbal learning and visuospatial learning, because they're going to have a lot of visuospatial impairment too.
Okay. Now, actually, I would like for us to talk a little bit about what other non-neurological things can actually present with these. But before we're going to go, maybe we just summarize everything what we talked about. And if we could pull the slide just for a minute or so, and maybe Dr. Lesser, you just summarize specifically about memory, about all of the conditions we were talking about.
Right. So on this slide, you'll see in the left-hand column are, cognition by domain, with the red and blue highlighted text there being really the crux of today's talk, that learning and memory system. And then along the top row, you'll see all the different disease pathologies that we've discussed today, and you'll see that, you know, Alzheimer's is really kind of the outlier. I mean, typical Alzheimer's disease, we're really seeing this profound and fast forgetting, this inability to retain new information they're exposed to, whereas the other conditions have more of the learning and retrieval difficulty. And then just, you know, for your reference, we have included some of the other cognitive domains typically affected by disease.
So, and just for viewers to really understand, because of the time constraints, we definitely cannot talk about every condition. So Alzheimer's is really not the only condition that presents with a retention deficit. There are other conditions that can present with that. We just didn't have time to talk about it. Sometimes they're called mimics. I don't think that's a correct term, you know, the mimics, because people really have problems, you know, about everything we'll be talking going forward. People really have cognitive problems. It's not I guess it's a mimic of Alzheimer's disease or mimic of dementia, but they really don't. Can either of you talk about the psychiatric disorders? How do they affect memory? Can people have memory problems with psychiatric disorders?
Sure, and actually we had a question from the audience about the overlap between cognitive disorders and depression. And that's a great sort of way to delve into what we think of as pseudo-dementia, which is really, you know, cognitive impairment underlined by psychiatric disease, by severe depression. And really, you know, it may functionally look and feel like forgetting, and there is some real functional impact. I mean, if a patient is severely depressed, they may, you know, have difficulty managing their day-to-day responsibilities. They may have impact from, you know, forgetfulness. Though when we see them in our neuropsychological evaluations, when we sort of control for effort and engagement, when those things, we have tests that kind of get at effort. When performance is normal on those effort engagement tasks, patients with depression or pseudo-dementia typically look pretty normal on cognitive testing. Where we might see a little bit of an impact is in retrieval and effortful retrieval, because that part of the memory process, when somebody has to freely recall something, requires a lot of mental effort. You know, and a patient that's severely depressed may lack motivation, may have a little trouble getting enough oomph to really kind of go and do the work of getting something out, may have a little bit of trouble with retrieval, but can demonstrate good learning and retention when we do test it out a little bit and add supportive cues and maybe some yes/no recognition.
Very interesting. You know, this topic, I think, asks for a separate conference, you know, over all the cognition and mental disorders, because one thing we do know that, you know, sometimes people when they're in their real life, they have trouble while you put them in the room for testing, controlled testing, you know, standardized testing, and they're doing fine on the testing. But they do struggle through the day-to-day thing. You know, what is that? Another thing, what we know with people with depression or mental disorders, there are functional changes in the brain that are affecting their memory system effectiveness. It's correctable with a treatment. If depression is treated, that corrects itself. But there are some functional changes in a connection. So again, that's very, very. So I'm never surprised to hear that people are having forgetfulness, attention problem when they have depression. The good news. The best news we can deliver, it's like it's not the neurological, not neurodegenerative disease.
Which is sometimes hard for patients to hear.
Absolutely, but it beats the alternative. It beats the
Right.
alternative.
From our perspective, it beats the alternative.
Yeah, it beats the alternative.
Now, part of that question was about cognition and Prozac. Can you speak to that at all?
So again, how SSRIs affect, we know the bottom line is that people who are treated for depression, for mood disorders, when their cognition improves. Okay, which SSRIs are better? Even with certain SSRIs were shown to, fatten, that memory areas. All right, if the cognitive problem is because of the mental disease has to be treated. The mental disease has to be treated.
Yeah, and one of the things that I sometimes tell my patients is, to not forget that the brain controls everything. Yeah. It controls function, it controls thinking, it controls mood. And a lot of the pathways that regulate emotional processing and even emotional regulation are some of the same pathways that regulate cognition. And so there are some associations that we can tease apart on the testing that we do that tells us this is more likely a cognitive manifestation of a acute psychiatric process rather than, more likely than, the cognitive manifestation of a neurological or degenerative process. And so sometimes it ends up being reassuring that, a psychiatric disorder can have emotional consequences and functional consequences and cognitive consequences, but the treatment should improve all of that.
What happens to memory and anxiety?
I don't know if you wanted to comment.
I mean, this is not. Well, go ahead.
I was going to say anxiety is going to be the big disruptor. It's going to keep you from focusing on sometimes what's most important to focus on, because you might be more distracted by the things that are preoccupying your mind. So it's going to make it really difficult to engage on anything meaningful for very long, if at all. And then it's going to actually create a lot of interference in the system. Even if you paid attention well enough to kind of initially get it, you then may quickly distract yourself with internal thoughts, worries, just pangs of anxiety that just disrupt those memory networks. And it derails the biological process of being able to create a new memory. And so anxiety in some ways can sometimes be even more detrimental than depression to memory specifically.
And the other thing, these people again might have completely normal testing.
Right.
Because they were able to concentrate for that time,
We were able to alleviate them and keep them quite calm and reassure them a little bit during the testing.
To make sure that they're calm and
because what we need is to really measure the neurological processes that underlie all of these cognitive abilities, trying to eliminate as much of that noise in the system as possible that in the day-to-day is going to be the primary influencer of changes in cognition.
Right. When I talk to my patients about, why is my emotional problem interfering with my memory, I kind of liken it to, when you are feeling stressed, even just depressed, anxious, your thoughts get internalized a lot more, and it's at the detriment of what's going on around you. So you're not as engaged with your environment when you have, some psychiatric dysfunction.
And neurological and psychiatric disorder. Same brain, it's all sharing the same network, so we're definitely not surprised to hear these. Aside from the psychiatric diseases or mental diseases, are there any other things that can affect our memory, effectiveness?
Medications, for sure. I mean, certainly talking about depression and treating depression, certain types of antidepressants, particularly those with a really high anticholinergic property. I think prescribing doctors tend to steer clear of those these days, but in a rare case, sometimes those are the most effective for treating the mood disorder in certain individuals. And the downside of that is going to be some changes in memory. But other kinds of, steroid use can affect memory processing. Antihistamines of a certain type and of a certain degree can interfere. But also, neuroinfections, and so metabolic disorders. So things like hypothyroid disorder that is either not yet recognized or insufficiently treated. Pituitary insufficiency, hypoglycemia that is not well controlled. These should produce, ideally, more transient disruptions in cognition more broadly, memory more specifically, provided that you can get that particular symptom under control. Severe vitamin deficiencies, so B12 deficiencies, thiamine deficiencies.
Thiamine deficiency can cause irreversible damage to the actual memory system.
Right, because of the territory territories that are responsible for creating new memories can be damaged in the setting of severe depletion of these minerals and vitamins on a chronic basis. Substances, so chronic alcohol use, I mean, talk about thiamine deficiency, when it's the alcohol use is to the detriment of typical nutritional intake, you can not only create an acute crisis, but then once you recover from that acute crisis, you may be left with some. Sleep apnea is another common reason for memory impairment. And again, if you can treat these sort of medical, systemic, metabolic abnormalities that seem to be exerting this acute influence on cognition, oftentimes you see that the individual can return to baseline. Again, could there be an underlying process? For sure, but these things are treatable. And so as the treating provider, our role, I think, is to, at minimum, let's identify all of the factors that we think are at play here, eliminate the ones that we can eliminate, sure, and follow this individual over time so that we can make sure, is the problem solved or is there cause for, concern down the road?
All right, and I think we left some time for questions, and one of the questions that came in was about the coconut oil, and I can talk about it a little bit. So one thing is, why are we, where's this coconut oil even coming from? The thinking behind the coconut oil is that, and that is specifically for Alzheimer's disease, that in Alzheimer's disease, there is some scientific data that our nerve cells are not, they're not using glucose as effectively as they could. And the coconut oil comes in, then we're trying to supplement these, the energy by providing some fats, and coconut oil is a fat. There is no scientific data for me to either recommend that or not recommend that right now. It just, there is not enough. The only thing what worries me about the coconut oil is that it has a lot of saturated fats, and it can definitely increase cholesterol levels, and that could increase the cardiovascular risk factor. So you really have to balance. While it sounds all natural, but it's not necessarily that benign, especially if you're using it in the large quantities. Any other thoughts about the coconut oil in Alzheimer's disease? No. Another question that came in is, there's we have this beautiful discussion here, about the memory and all these stages and how it affects. While we're still waiting for in neurological diseases, while we're still waiting for these meaningful disease-modifying therapies, how do we treat them? What do we do?
Well, I mean, a lot of it is about ruling out anything treatable. Mm-hmm. And, when there is vascular disease, unfortunately, in our culture is just something that's relatively common. I mean, there's a lot of underlying cerebrovascular risk factors, diabetes, hypertension, high cholesterol, as you suggested, lack of activity, being overweight, all of those things put you at higher risk of developing, vascular cognitive impairment. So, and not just in the context of vascular disease, but a lot of times we're prescribing lifestyle changes, and trying to minimize
that even people with Alzheimer's disease or mild stages, that you have to address these cardiovascular risk factors or improve their cardiovascular health, because it's all interconnected.
Right.
It's good for the heart, it's good for the brain.
Yes.
I tell my patients that all the time.
Yeah.
Whatever is good for the heart is good for the brain. Regular exercise, eating a healthy diet, typically along the lines of a Mediterranean diet,
yes,
sort of the most beneficial. The cardiovascular exercise, so walking, but also some degree of strength training can also be beneficial as well. I didn't mean to cut you off, but in terms of actual cognitive training techniques, there's been a lot of success, and there's some mixed results in the literature in terms of which types of cognitive training paradigms, if you will, are most effective. And really, when you break it down, there are two general types of cognitive training resources for individuals with cognitive problem more generally, memory problems more specifically. Compensatory strategies and restorative strategies. And in the literature, both seem to be about equal in terms of helping the individual, but a restorative technique-based strategy would be trying to train up the weak or impaired areas of cognition. A compensatory-based kind of strategy would be about capitalizing on the strengths to work around the impaired or weak areas. Really, anything that is going to create a lot of novel experiences that are rich in terms of cognitive stimulation, social stimulation, and whenever possible, just some physical stimulation, are going to be best for the individual. And so it doesn't necessarily need to be a particular training event for the individual, but staying socially and cognitively engaged on a regular basis is going to have some benefit.
We're almost running out of time. Dr. Lester, 20 seconds. Sleep. Importance of sleep in memory.
Sleep is very important. I mean, if you are underslept, I think everyone has probably had the experience of not getting enough sleep and how that kind of makes your brain and thinking a little bit fuzzy. And it really, again, comes down to the attentional system. I mean, if you're chronically fatigued, you're just not as engaged or alert or attentive. It's a hierarchy. You have to be awake, alert, or and attentive to learn information.
So 20 seconds. I have to
Sorry.
There are also medications we could use in the specific diseases again, but this is for the next talk. So.